Assalamu alaikum and good morning, everyone. I am Dr. Rabeea Saleem, and I'm going to present a brief idea about the urolithiasis, that how do they form, how we can prevent it, and how we can treat it. So, what is a stone? Stone is a polycrystalline aggregate composed of varying amounts of crystalloids and organic matrix. Urolithiasis is a Greek word which means the condition where urinary stones are formed or located anywhere in the urinary tract, including kidney, ureter, or bladder. It is common disease that is estimated to produce medical cost of about 2.1 billion US dollars per year in the United States alone. In this red, we can see this is the stone belt area, and it extends all the way around the world and is characterized by urinary stone prevalence of around 10 to 15%. Overall prevalence of stone disease is 1 to 15%, most at the age between 20 and 49 years. The male to female ratio is 3:1, and the peak incidence in the third and the fourth decades of life. The prevalence in different ethnic groups is different, and in a study, it has been shown that there is a risk of 29% in Egyptians, 25% in Pakistanis, 23% in Indians, 20% in Yemenis, 17.6% of Sudanese, 16% of Bangladeshi people, and 7.4% of Saudi Arabian people can have a chance of developing urinary tract calculi in their life. The incidence of urolithiasis in the pediatric population is increased nearly by 5-fold during the last decade. The most common metabolic abnormality was hypocytruria, followed by hypercalciuria. A family history of kidney stone disease increases the risk by 2.5 times. In Germany, a nationwide survey showed an increase in both the incidence and prevalence between 1979 and 2001. 50% of patients suffer at least one recurrence, and 10 to 20% experience 3 or more further episodes of urolithiasis in 10 years, even after complete clearance. In the past 2 decades, the incidence has been rising predominantly between the ages of 40 and 49 years. The National Health and Nutritional Examination Survey showed increasing rates of stone disease in men up to 65 years and in women up to 70 years. So, this is a diagram which we can appreciate that the ureter and the kidney makes the upper tract, and the urethra and the bladder makes the lower tract. Around 95% of the urinary stones are found in the kidneys and the ureter, means there are 97% upper tract stones and 3% are lower tract stones. Most of the time, the stone composition is calcium. It makes around 70 to 80%, followed by struvite, cysteine, and uric acid. Uric acid are the soft stones, and the calcium oxalate are the most hard stones. And the hardness of the stone we can depict on the basis of the CT scan, in which we can see the Hounsfield units. Pathogenesis. The physical process of stone formation comprises a complex cascade of events that occurs as the glomerular filtrate traverses the nephron. The steps of stone formation are supersaturation, nucleation, growth, aggregation, and retention. These all steps are very well seen in this video.
Stone formed. The first step is nucleation. Ions such as calcium.
Voice.
Stone formed. The first step is nucleation. Ions such as calcium and oxalate that have been filtered into the urine by the kidney spontaneously join together to form a solid crystal nidus. This is called nucleation. There are 2 kinds of nucleation. In homogeneous nucleation, crystals form around a nucleus with the same composition. Crystals of a different composition can also form around the nucleus. Organic materials, such as cell debris, may be deposited between the crystals as a matrix. This is heterogeneous nucleation. The tiny crystal formations travel down the nephron and are usually deposited at the renal papilla, where they undergo the next major phase, growth. Crystals that have already formed then begin to stick together, forming large aggregates. As we can see, crystals can aggregate very quickly. New stones are retained in the kidney, where they can continue to grow for an unspecified length of time until, for reasons that are not well understood, they are displaced and travel through the kidney into the ureter. If a stone continues to grow until it reaches a critical size, which can be as small as 4 to 5 millimeters in diameter, it may be too large to pass easily through the ureter. The edges of the stone may become wedged inside the ureter at the ureteropelvic junction, where the ureter crosses over the iliac artery, or at the ureterovesical junction. The result? Pain and obstruction, until the stone slowly passes into the bladder and eventually passes out of the body in the urine stream. Stone formed.
So these are the theories of stone formation, which we will discuss one by one in our later slides. The nucleation theory. The urinary stones originate from the crystals or other nidai immersed in supersaturated urine. These are all the steps of stone formation which we just see in our video. The supersaturation leads to nucleation, followed by crystal growth, aggregation, and finally the stone formation. This is the nucleation. Heterogeneous nucleation is the one in which, other than the crystals, epithelial debris and cells are also attached to the aggregates and the crystals. The crystal inhibitor theory states that the calculi form in the absence or low concentration of natural stone inhibitors, which include magnesium, citrate, pyrophosphate, and a variety of trace metals. But this theory doesn't have absolute validity because many people lacking such inhibitors may never form stones, and other with an abundance of inhibitors may paradoxically form stones. The other is the fixed particle theory, which was described by Randall, an anchoring site to which crystals bind, prolonging the time crystals are exposed to the supersaturated urine, facilitating growth and aggregation of the crystals, and finally the stone formation. Randall first suspected renal papilla as the anchoring site. Subepithelial plaques originating from the base membranes, these are the sites where the stone formation starts. The nanoparticle theory is an unproven hypothesis for the origin of the calcium phosphate crystals. It involves calcifying nanoparticles, including nanobacteria, which are also implicated in other type of pathologic calcifications like atherosclerosis plaques. The ductal plaque theory, it says that the apatite crystals or the phosphate crystals, they deposit plug into the medullary collecting system and then leading to the cell injury, enlargement, and cell death. As a result, there is interstitial inflammation and progressive involvement of the adjacent tissues. It is implicated in mostly in the phosphate stone. Presence of ductal plugs should raise the suspicion for the secondary cause of the stone formation, which is observed in various metabolic conditions like renal tubular acidosis, hyperparathyroidism, and cystinuria. This is the unified theory in which we can see that this urinary supersaturations, there is a slow transient of urine from the ducts leading to the crystal formation here associated surrounding tissue edema and hence the stone formation in the end. The Carr's hypothesis is that the calculi form in obstructed lymphatics and then rupture into the adjacent fornices of the calyx. The argue against the Carr theory are the grossly visible early stone elements in the areas which are remote from the renal calyceal fornices. So there are certain factors which affect the stone formation, include intrinsic and extrinsic factors. The intrinsic factors include the age. The peak incidence is 4th to 6th decade of life. Women show a bimodal distribution. Second peak incidence is in 6th decade of life. This is most of the time because the women present late in their age with the stone. It is because of the protective effect of estrogen, which causes delayed stone formation. Gender is male to female ratio is 3:1, and the males have higher concentration of urinary calcium, oxalate, and uric acid. However, the females have higher concentrations of urinary citrate, leading to stone formation. The metabolic syndrome causes an increased excretion of stone-promoting substances like low urinary pH, oxalate, calcium, uric acid, and phosphorus, and the decrease the excretion of stone-preventing substances like citrate. The race and ethnicity includes the Caucasians have the highest incidence of stone formation, followed by Hispanics, then Asians and Africans. The persons who have the family history of stone, they have the highest risk of they have the higher chances of forming a stone in their life. Later, other genetic disorders are familial renal tubular acidosis, cystinuria, xanthinuria, primary hyperoxaluria, and cystic fibrosis. The extrinsic factors include the geography. The high incidence of stone is found in hot, arid, and dry climate. However, the genetic factors and dietary influences may overweight the effect of geography. High stone prevalence included in USA, Scandinavian and Mediterranean countries, North India, Pakistan, Australia, Central Europe, and China. Those who are exposed to the high temperature, they exhibit low urine volumes and pH, high uric acid level in the blood, leading to high urine specific gravity, followed by urine supersaturation of uric acid. Certain occupation also lead to the formation of stone, like the persons who work in high ambient temperature, the person who have sedentary occupations, and those who have limited access to the toilets. It means that they drink less water because of the limited access of the toilet. As a result, they form the concentrated urine, and finally, the stone formation. Low fluid intake, again, the diet is high animal protein intake, high urinary oxalate. It causes high urinary oxalate, low pH, and low urinary citrate. However, the high salt intake leads to hypercalciuria. So that's the reason that the persons who are prone to form stones, or who are recurrent stone formers, or who have stone disease, we say that please don't add extra salt to their meals. These are the risk factors in the persons who can develop stones. The general factors include the early onset of urolithiasis, like the childhood. Others, the family history, the recurrent stone formation, uric acid stones, and the recurrent UTIs. The other causes include metabolic diseases, which are like hyperparathyroidism, metabolic syndromes, and GI disorders. Drug-induced certain antiviral drugs also lead to the formation of indinavir. Indinavir can also lead to the formation of certain stones, like sulfur drugs. Some anatomical abnormalities also lead to the formation of stones because of the stasis of the urine, like horseshoe kidney, pelvic-ureteric or vesico-ureteric junction obstruction, vesico-ureteric reflux disease, or calyceal diverticulum, or obstruction as a result of benign prostatic hyperplasia or stricture urethra. Certain environmental factors include high ambient temperatures, and genetically determined factors are cystinuria, primary hyperoxaluria, renal tubular acidosis, xanthinuria, and cystic fibrosis. The risk of recurrence is 50 to 80%, depending upon the type of stone, unless secondary prevention is instituted. Risk adapted secondary prevention lowers this risk up to 10 to 15% only. The symptoms. Most of the times, the patient present with different symptoms. Sometimes they present with pain, backache. Sometimes they present with fever because of obstruction or vomiting or hematuria. Pain is the most common symptom, accounts for about 75%, followed by hematuria, UTIs, lower urinary tract symptoms, uremic symptoms, and silent calculus, especially in older age people. If the person presents with the uremic symptoms and there is advanced uremia there, then these patients undergo hemodialysis first after we treat for the stone. Other individuals or older individuals are more likely to present with atypical or no pain, fever, diarrhea, polyuria, urinary tract infections, and bacteremia. Each decade of life increases the risk of UTI. The most common organisms cultured are E. coli, followed by Klebsiella and Proteus mirabilis. The overall females are more likely to present with a UTI than the males. The commonest symptom of urolithiasis in pediatric age group is abdominal pain. In one report, abdominal pain was present in about 40% of school-aged children and urolithiasis. However, in infants and children, the pain is only relatively recognized as non-specific abdominal pain and thus difficult to differentiate from other causes. For hematuria, its prevalence as a presenting symptom for childhood urolithiasis varied from 30 to 55%. Only 10% of the children with urolithiasis present with symptoms of dysuria and urgency. So how do we diagnose the stones? The sensitivity of ultrasound for the diagnosis of ureteric stone is 85% and specificity is 50% only. The sensitivity of the ultrasound for the detection of renal stone is 67%, the specificity is 100%, and the accuracy is 81%. The overall accuracy of ultrasound to detect the ureteric stone is 80%. Plain radiography also lacks specificity, as phleboliths, which are common pelvic calcifications, are not always readily differentiated from the urinary tract calculi. Non-contrast enhanced CT scan have 95% sensitivity and 97% specificity for the detection of renal calculi, and hence it is a gold standard method of detecting the renal stones. So how do we prevent it? Drink enough fluids in order to maintain a urine output of about 2 to 2.5 liters per day. Avoid eating too much animal protein. Eat less salt. Include the right amount of calcium in the diet. Advise patients that a generous fluid intake is to be maintained in order to make a urine volume of about 2 to 2.5 liters. Individualized risk adapted metaphylaxis reduces the risk of recurrence from 50 to around 15%. Eat less oxalate rich foods like nuts, beets, chocolate, soy, etc. and the metaphylaxis in terms of medicine. These are the pharmacological treatments or the drugs used for the prevention of stone, which include alkaline citrates, causes the alkalinization of urine. In order to treat the stone type of calcium, uric acid, and cysteine, along with the sodium bicarbonate, we can also give for the alkalinization of urine. Allopurinol is also used in case of calcium oxalate and uric acid stones, and Fibexid also for the calcium oxalate and uric acid stones. Disease management. It includes management in acute emergency setting and then definitive management, including rendering patients stone-free as well as starting metaphylaxis. Around 1% of all hospital admissions are attributed to renal colic. The debilitating pain of acute renal colic, often described as the worst pain ever experienced, warrants rapid pain relief. Intravenous paracetamol is a centrally acting analgesic rapidly crossing the blood-brain barrier, providing quick pain relief. A recent study by Zadeh et al. Advocated using paracetamol in renal colic due to its efficacy similar to ketorolac with fewer adverse effects. However, its effect has yet to be studied in the subcontinental population. According to the European Association of Urology, it recommends that the non-steroidal anti-inflammatory drugs are the first choice of drug for the management of pain, followed by opioids. But if the patient has refractory pain despite maximal analgesia, we should go for urinary tract decompression. Management of obstruction. An obstructed renal or ureteric stone can be dealt by performing definitive surgical procedures. However, it is not feasible in patient having acute urinary tract infection. In such cases, urinary diversion, either by performing percutaneous nephrostomy or placing an indwelling double-J stent, can be done, and the definitive surgery can be performed later. The aim of doing this urinary diversion is to decrease the renal pressure and prevent the renal unit from the deterioration. These are the two radiographs in which we can see this is the proximal ureteric stone causing the obstruction of the kidney, in which the double J stent has been placed in order to relieve the obstruction and prevent the renal unit. However, in this radiograph, we can see that there are stones all They are present in the whole of the proximal and the mid ureter and the kidney also. So in this case, the decompression was done by means of percutaneous nephrostomy, because if you could have access from down, it would have been difficult to place a double J stent. So percutaneous nephrostomy was a better option to go with in order to prevent the renal unit. Hematuria and UTI. Hematuria usually settles with conservative management, like, for example, oral and IV hydration, and rarely require any surgical or radiological intervention. For urinary tract infection, patient should be admitted and antibiotic is started as per the culture and the sensitivity, or we can start with broad spectrum antibiotic prophylaxis. Patient with urosepsis needs ICU admission, managed by IV hydration, broad spectrum antibiotics, good pain management, and supportive care. An obstructed upper urinary tract stone leading to pyelonephrosis should be managed with percutaneous nephrostomy or drain if there is a renal abscess or perinephric collection. This is the medical expulsive therapy, and according to the European Association of Urology, it states that the patients who have distal ureteric stones, even more than 5 mm, 5 to 6 mm, they can be managed conservatively by means of giving the alpha blockers, and it has also good results. Surgical management. The surgical management depends upon multiple factors, including the size of the stone, the site of the stone, and the condition of the patient. If there is a kidney stone which is measuring more than 2 centimeter or 2 centimeter, the gold standard is PCNL, followed by retrograde intrarenal surgery, or in the end, shockwave lithotripsy. In between 1 to 2 centimeter, we can manage the stone by retrograde intrarenal surgery or shockwave lithotripsy. And if it is less than 1 centimeter, then extracorporeal shockwave lithotripsy is the treatment of choice. But if it is lower calyceal stone or the stone in the calyceal diverticulum, then it cannot be treated by shockwave lithotripsy. Then we need to go for the PCNL in order to puncture that particular calyx or that particular diverticulum. Now, for the ureteric stones, the proximal and the distal ureteric stones, the management is same. It is uterinoscopy followed or lithotripsy later on. The complications are chronic renal failure. If the stone is long-standing, it was initially asymptomatic, and it can lead to the deterioration of the renal unit, and sometimes the patient present with renal failure. Sometimes because of the acute obstruction, there is acute renal failure. UTI, sepsis, collecting system rupture also happens, leading to the collection of retroperitoneum, hematuria, pyonephrosis, stricture or pelvic junction obstruction. It is because when the stone passes through these mucosa, they lead to the edema. And once they cause edema, so there is a fibrosis followed by stricture formation. Or very rarely, renal or bladder carcinoma, and the type of carcinoma is a squamous cell. So the take-home message is, renal stone is a common disease in pediatric and adult population, which causes significant morbidity. Focus should be on making the patient stone-free as well as preventing the recurrence by changing the lifestyle, diet, and prescribing metaphylaxis. These are my references.